as possible, and it is affordable. How can we deliver these two simple, affordable interventions to all those individuals who need them? We need to come up with a mechanism of ensuring that zinc and ORS is available. The Clinton Foundation in Uganda, and probably in other countries in East Africa, has been doing a lot of work in here. And through public-private partnerships, we think it can be done and we can scale up this simple intervention. Routine childhood immunizations have been with us for a long time. On the left side of the slide are the routine immunizations, and I used measles to show how well we have done. And as you can see, we are doing very well for measles coverage. Okay? And on the right side is some of the newly introduced vaccines. They are new life-saving vaccines. These include pneumococcal vaccine for pneumonia, rotavirus vaccine for diarrhea, Haemophilus influenza B, and human papillomavirus and hepatitis B vaccine. Fortunately, East African community is already working through a regional immunization program to ensure that member countries or member states introduce these vaccines. And that initiative is supported by Gavi Alliance, and also the Federal Republic of Germany. And I'm sure in the course of the 2 days we shall be hearing details about that. Next, please. Malaria, insecticide-treated nets. This intervention has been around, but we need to make sure we bring these interventions to scale. We know that insecticide-treated nets can reduce the risk of death among under 5 children from all causes by 20%. And we know that a mosquito net in this house will reduce the number of infective mosquito bites within a radius of 30 meters from the ITNs. So why don't we scale up ITNs? Simple, affordable, and effective. Let's move to maternal mortality. And again here, we have seen good news. Again, we are going back to some bad news, okay? In maternal mortality ratio, as you have heard, it is only Rwanda which has achieved MDG 5A goal of reducing maternal mortality by 3/4 between 1990 and 2015. None of, clap louder for them, please. None of the other East African countries are expected to achieve this target until after 2025. It is too far. The Minister of State for Health Services in Uganda said he needs to make a difference, and he needs to make a difference soon. And I don't think he can wait until 2025. So together, collectively, we need to do something about this. So what are the causes of maternal mortality? Why aren't we able to reduce maternal mortality? I went to medical school many years back. I cannot say how many years back. So I was curious this time. I looked very hard to see if there were any new causes, but they are the same causes that we were taught. They're exactly the same causes. Hemorrhage, okay? Hemorrhage, pre-existing conditions. I remember, yes, that slide. I remember hypertensive disorders, eclampsia and pre-eclampsia, sepsis, embolism, complications from unsafe abortions. Who can tell me if there's anything new that we have not known about over the last 50 years? I was not in school 50 years ago, but you get the idea, okay? If a woman starts bleeding in a lower level health unit, by the time they mobilize transport and take her to the health facility, which is many miles away, she reaches and she's pronounced dead on arrival, okay? But with this, we can keep her alive. So long as it is applied, she will stay alive until she gets to the higher level facility, irrespective of how long it takes. Within reason, obviously. We can't take days and days. Next, please. I want to mention pre-eclampsia and eclampsia. It has been with us for a long time. The key thing is we need to train our healthcare providers to be able to recognize the danger signs early. A simple blood pressure measurement, a simple talking to the person may be able to recognize which people are in pre-eclampsia or which people have impending eclampsia. And magnesium sulfate can be used for both prophylaxis or treatment. Next, please. MDG 5B, contraceptive prevalence. Here we have not done well at all. This is another goal where we need to make sure that we do something. As I mentioned, 95% coverage is what we are calling universal, and no country in the East African member states, East African Community partner states, has reached the target. Okay. There is research about Depo-Provera, which is an injectable contraceptive, and which also is the region's method of choice because it is effective, it is simple to re-inject, and can be used discreetly by women, especially those who don't want their spouses to know. Secondly, you can train community health workers and also paramedicals to provide or to inject and re-inject every 3 months. Can we have guidelines to train community health workers to provide Depo-Provera? There has been some hesitation among some professional associations for reasons which are well understood, but we need to do something. We definitely need to do something about this. So, we started off with the good news, and I apologize that I led you into dismal news, which shows that we have made progress, but we are not on target. And unless we do something, we cannot hit the target. It's already a bit late because September 2015 is just around the corner, but if we can hit the targets within the next 1 to 5 years, I think it should be good. So do we have what it takes? In terms of what it takes, I'm going to focus mainly on 2 aspects. The keynote speaker this morning talked about the functional health systems and the building blocks, the WHO building blocks, and so on and so forth. That really has made it easy for me, so I don't have to emphasize. Next, please. This graph shows the Indians, and we have people which are on the left are all very important. Right now, we have a poorly functioning health system and infrastructure. It is characterized by inadequate numbers of health workers and suboptimal performance of those health workers who are there. There are multiple uncoordinated actors, public and private. We heard this morning public-private partnership policies are being passed within member states, so that is a good thing, okay? These different actors have different priorities and different modes of working. So we need to make sure that we are coordinated better, okay? We also have an underdeveloped service management capacity. Next, please. Among the building blocks, just to mention, they are all important. But leadership, governance, health financing, health workforce, and the service delivery are very key. And you can see why they are key on that slide. Next slide, please. I need to mention also that in addition, social inequity and culture or religious factors influence the uptake of interventions and thus create bottlenecks. We are generating evidence, as you heard from one of the speakers in this room, there are researchers generating the evidence to show which cheap or simple, affordable interventions are cost effective, but we need to make sure that we create the demand, we need to make sure that these interventions will be taken up. So if there are any bottlenecks in this area, we need to make sure that we bring people who understand culture, anthropologists, and social scientists to be able to teach us how to be able to make it. Next slide, please. I'm nearly finishing. If I've gone beyond, I apologize. So going forward, what do we need going forward? And we have already heard. We have heard that going forward, we need to build on the post-2015 development agenda, and we need to move from MDGs to SDGs. We have to acknowledge there's demographic change, and there are growing environmental pressures. We need to do something about the demographic change and the growing environmental pressures. Fertility. I've been so impressed by the Honorable Minister when he said he's one of the few men, I was going to say in this room, but let's say men in the region who have 2 children. And I think he needs to be congratulated for that. Yeah. With 2 children, you look after them well, you educate them very well, you feed them very well. They will have 2 children each, and the cycle will continue. This is what we need to be doing. So let's make sure that we do that. We also need to break the cycle of unsustainable consumption, and we need to reset norms around fertility rate, which I've mentioned, and consumption patterns. Leadership is very key. I cannot overemphasize this. The keynote address this morning, I mentioned many of these aspects of leadership, but we need to make sure that there is coherence between national commitments and resource allocations. Many times, the commitments are made, allocations are made, transfers not made, and even if transfers are made, money not utilized and returned back. We need to make sure that leadership at all levels of the healthcare ensures that this process works well. Ministries of Health, focus on health financing, human resources for health, and please do not forget quality and equitable health service delivery. The multi-sectoral response. We applaud our development partners for standing with us. We need to be more coordinated, and we need to make appropriate utilization of the resources which are available. Many times we send the resources back, unfortunately. We need to make sure that doesn't happen. Priority number 2, next slide please, is human resources for health. We have talked about human resources for health. We need to increase production, although personally I feel production is very high. We need to ensure equitable distribution, and we need to ensure retention. Retention. I think I'm going to be told that time is up, so I should finish. Next, please. Ladies and gentlemen, later today in the dinner gala, I see on the program, I hope it is okay, I hope it hasn't changed, that a hard-working healthcare provider, Esther Madudu, who is a midwife, is going to be recognized. She's the face of Amref Health Africa campaign, and she's a symbolic nominee for the Nobel Peace Prize 2015. She's representing all midwives who work so hard and deliver 50 women every night, okay, and do not rest, and they are not appreciated. So we hope you'll be there, and we hope she will be recognized. Priority number 3, next please, are commodities. Let's make sure that we scale up availability of life-saving commodities for maternal health, newborn health, child health, and reproductive health. Next please. This slide is priority number 4, but I think I'll take a bit of time to also use it to summarize the presentation. Priority 4 is we need to scale up quality services, being cognizant of the continuum of care, okay? We need to be aware of the political, economic, social, technological, and environmental context. Working within that context and the context of health sector policies, sound health sector policies, and multi-sectoral policies, we should deliver our interventions. And the interventions on those slides at the different aspects of the continuum of care should be able to deliver us to reduced preventable mortality and improved health and nutrition for women and children. So it is priority number 4, but it also more or less summarizes what we have said today. Next, please. So as you have heard, we need champions. We need champions, next please, who are strong movers and strong shakers, okay? We have heard today, one of the speakers on the panel here mentioned that our first ladies are champions in reproductive, maternal, neonatal child health. I was so impressed when I was preparing for this, and I searched about them and wrote about them. They have all been champions. They have founded organizations, they have been champions for public health interventions, and they have done a great job. We need to encourage them to do better, and we need ourselves to become champions and change agents or movers and shakers. Ladies and gentlemen, thank you for your attention. With this slide, I need to emphasize that we should harness innovative information communication technology to send our messages using mHealth to remind our clients to take their medications. Thank you for your attention.
Thank you very much, Professor Wabwire Mangen. Can we give him another round of applause? Indeed, you have reminded us, and I am sure that many of us have been moved by this presentation. We really need to get down to work and address MDGs 4 and 5. Okay, I didn't request for lights to go off. It is now my pleasure to invite the chair of the East African Community Sectoral Council of Ministers of Health and the Minister of Health and Social Welfare of Tanzania to officially open this session. Honorable Minister, you're welcome. Can we have these lights on, please? Immediately after he has opened officially, we shall have the high-level panel discussion on transforming lessons from MDG era into robust actions for accelerated elimination of preventable maternal, newborn, and child death in the East African community post-2015. It will be a question and answer session, and our host will be Honorable Jessica Erio, together with Honorable Dr. Chris Bariomonsi. I will thereafter request the rest of the ministers from the high table to take your seats on the other side, and the panelists will be invited up. Honorable Chair.
Some lights on, please. Yeah, thank you for giving me the podium at this challenging moment, because most of the time postprandial other people tend a little bit to close some eyes, but I believe the presentation was really exciting. I was trying to scan around my eyes, but everybody was quite alert. So let me take a few moments to officiate this important meeting here, then we'll continue with the discussions. And, I understand as I'm embarking on the panel discussion, everyone will be quite alert. Honorable Ministers of Health from the EAC partner states, Honorable Erio Jessica, Deputy Secretary General, East African Community, Honorable Dr. Odette Nyiramirimo, representing Right Honorable Speaker EALA, Honorable Members of Parliament from EALA and National Assemblies, members of the Diplomatic Corps, development partners, members of the media, ladies and gentlemen. It is an honor for me to welcome you to the second EAC Health Ministers and Parliamentarians Forum on Reproductive, Maternal, Newborn, Child and Adolescent Health, which is being held together with the EAC Regional Symposium on Accelerating and Sustaining Progress in Women and Children's Health post-2015. Witnessing commendable decline in maternal mortality, the current levels of 500 per 100 live births in the Republic of Burundi, 360 per 100 live births in Republic of Kenya, 291 per 100 live births in the Republic of Rwanda, 410 per 100,000 live births in the United Republic of Tanzania, and 360 per 100,000 live births in the Republic of Uganda are still unacceptably really high. The rates of under 5 mortality and the neonatal mortality are equally unacceptably high. However, ladies and gentlemen, as we turn the final end of the MDGs era and move into the post-2015 development era, I call upon each one of us to tighten our belts to do things differently. But how prepared are we to do things differently? This is a question we have to ask ourselves. Are we ready to forget our comfort zones for the sake of our children, sisters, and mothers? In other countries in the Western, even one death of the mother because of the birth is really announced as a catastrophe. This is a long way. We in the eastern part of the African continent, we have to really pull our socks and do the things differently. We have a number of models around the region, but how about the level of implementation? We are very great. The policy makers are here, decision makers, technocrats, actors at the local level, development partners at that range, including academicians. But how are we using the data, the results? Fancy PhDs, fancy masters through dissertations, thesis, etc. But many places you go, these good practical documents are lying, you see, in the shelves. Others do the citation, the references, and so on. But it's high time now the East African region will use these results for changing the situation we are. Yeah, we should not spend a lot of money, quite expensive, these studies, operational researches, others about medical, but towards improvement. In the morning when the guest of honor, Honorable Vice President for Uganda, was really stressing the powers you have, the potentials you have in this region. Let's expend it fully to make sure we change the course in this region. Ladies and gentlemen, it's really fair to say it is no longer any secret that we can actually avert most of the maternal and the under 5 deaths that we continue to see in our homes, communities, and the health facilities. For example, we know that reducing the number of unintended pregnancies could avert up to 60% of maternal deaths and 57% of the child deaths, which is quite remarkable. We also know that immunization is a very cost-effective intervention in reducing vaccine-preventable diseases. Furthermore, we now have the power to ensure children are born free of HIV. These are but a few of the myriad of interventions that we know work and are quite cost-effective. Ladies and gentlemen, I'm aware and grateful of the good work that you do. My fellow honorable ministers and members of parliament and the various policymakers and the practitioners, are doing to uplift the health and the well-being of our mothers and children. They are good enough for MPs who are seated here and other representatives. It's good the data we gather from various sources. You use them to argue, to challenge about the budgets which are presented. It's a long way since 2001, when the heads of state in the African continent met in Abuja and agreed. But how about the level of implementation? The way we see, and if you visit the website on public health in Africa, you can really see all these data are plugged there. And I applaud Rwanda. They have been outstanding from many times. On the budget, let's try to tally the budget and the allocation. The general budget, how is it? How is the health placed in the sharing of the cake? Through the data gathered by World Bank and World Health Organization many years back, they really showed if you don't address properly on health, even the economic rundown will be quite high. So it's good to use this relevant data to make sure we convince the decision makers, including the Minister of Finance. Sometimes if you don't argue better with the data, statistics, it's easy the Minister of Finance to fix you. They say, why are you arguing? You say this is the formula and this is the ceiling. Why do you need more money? And they have been given the ceiling. So I urge that my colleagues who are seated here, let's act better, differently by data, so that we convince and get more money for health. We are definitely not yet there. I therefore call upon all of you to do much more towards improving reproductive, maternal, newborn, and child health now that we are armed with better lessons so painfully learned for so many years. When a mother died because of pregnancy related causes, to any part of the world, it's basically a community epidemic to many places, and it touches everybody. So it's good as a community, as a humankind, we change the way we are operating. The causes of maternal deaths, you mentioned them, there are quite many, but hemorrhage is ranking, it's number one in the killing for many years. We thank you, Professor, he's just enlightened us. Hemorrhage, how are we preparing to counter effect the hemorrhage? The technocrats, they get information, they teach to the local level, to the community workers. But the issue of blood availability, how is it? How is the service level of the safe blood? Are we still operating at the 30%, 40%? Surely these mothers will continue dying, because the main cause, number one, is the hemorrhage. Then you don't have blood. What do? So colleagues who are seated here, let's frankly try to be practical. If the blood availability is there, you save a lot of lives. And also the communities changing with the level of knowledge and education, because if you tally, you find a lot of mothers who die, unfortunately, are those with low level education. What do we do to rescue these women? They are our mothers, they are our sisters, they are our wives, they are our neighbors, they are everybody. So it's good we rescue these poor women, including the children. Unfortunately, the children, they die silently. They don't speak out, they don't defend themselves. It's we who are seated here who have to avert the direction. We are the ones to speak for them. It is my expectation that the quality research and the scientific papers that will be presented at this symposium will contribute towards implementation of evidence-based homegrown solutions. Ladies and gentlemen, recent evidence shows that with the pretty small increments in per capita funding, you can take high-impact maternal and child health interventions to majority of the people who need them most. Members who are seated here, if you go by data suggested by WHO in the developing world, at least per capita you have to allocate 30 to around 40 USD. Are we there? In the East African region, none of the countries which have reached there. Fairly, we can go above 15% of the budget allocation. But if you calculate per capita how much has been allocated, so we still operate in the very constrained situation. We have also to counter the budgeted per capita, which is very important, and will really help us much. Ladies and gentlemen, recent evidence shows that with the pretty small increments, as I said, we can take really a high impact. The Global Investment Framework for Women's and Children's Health estimates that with an investment of additional $5 USD per person per year to expand the access to and the use of 50 effective interventions across the continuum of care. The deaths of 147 million children, including 60 million newborns, 32 million stillbirths, and 5 million maternal deaths can be avoided by 2035. This investment will yield a return of close to ninefold in the form of social and economic benefits over the 23-year period, which is really great. 2012 to 2035, considered by the framework for a group of 74 countries, all from partner states inclusive, with the highest burden of maternal, newborn, and child deaths. Ladies and gentlemen, it is gratifying to learn that this second health ministers and the parliamentarian forum on reproductive, maternal, and child health
effective intervention for reducing maternal mortality. And we really need to look at this because often this decision, and I liked the minister who said he was empowered to have the right number of children he desired and at the time when he wanted them, that we really need to look at the issue of family planning and contraception. It's very effective for not only enabling people to achieve their reproductive goals, but also it's a very effective strategy for preventing maternal mortality. I think focused antenatal care that focuses to deliver specific interventions. We've been shown, for example, hypertensive disease mortality. We really need to look at the antenatal care services we are providing, and finally, to look at the issue around the time of delivery. A lot of mortality happens around the time of delivery, either intrapartum or in the immediate postpartum period. So I think from our perspective now and from the lessons from the countries that have been successful, we need to look at focus on specific high return interventions that can be able to have an impact on these areas that we want to have an impact on. Just to close, I would like to highlight some of the things that in WHO that we are working on to really move on to the post-2015 agenda. Because as we move into sustainable development goals, And we know that there will be also a health goal within the Sustainable Development Goals. We need to look at what should be our next targets and what are some of the things we need to do so that we move into the post-2015 agenda. One of the things that I would like, there are many things that are happening, but I'll just highlight two of them. In the Reproductive Health Research Department, we've been the secretariat for the Implementing Best Practices initiative. Many of you are from organizations that are members of that initiative. We have about 44 partner organizations, including EXA. There is EXA, which is also one of our partners. And this is really looking at advancing and scaling up effective practices that contribute to universal access and quality of reproductive health and family planning services. So we are looking forward to continuing this initiative, particularly with a focus on the issue of scaling up, because interventions can be very effective, but if they are not scaled up, then they do not really impact the numbers or benefit the people that we want to benefit. And the second thing I would like to say is that the UN Secretary General strategy for women, children, and adolescent health is currently in the process of being updated. And there's going to be a consultative forum in South Africa, which is going to be on 6th to 7th of May. And those of you in governments will soon be receiving invitations also to civil society and all parliamentarians and other stakeholders to really consult on this issue. This agenda will take us from 2016 to 2030, and it will be very important because it will also focus on the unfinished MDG agenda. As we know, there's a lot of unfinished business. So although we are leaving the MDGs, moving to the SDGs, we know there's a lot of unfinished business. And it will also now focus on critical population groups that we know, for example, newborn and adolescents, look at health systems more intensely than before, and also the issue of quality services and coverage. And this will also look at the health sector enhancing areas, for example, at water and sanitation and education and so on. And therefore, those are the two things I wanted to highlight that we are going to do to move to the post-2015 agenda. And again, thank you very much, Chair. I hope I've not eaten into the other panelists' time. Sometimes always the benefit of being fast, but thank you very much.
So thank you very much, James. Let's give him another round of applause for the key intervention. Let me take the opportunity to introduce the next speaker, Madame Robin Gona. She also has a very detailed and rich CV, but because of time, we want to go into it. But briefly, she is the Executive Director for the Partnership for Maternal, Newborn and Child Health, and a very strong advocate and strategist with a strong track record for leading effective action on sexual and reproductive health and rights. And she has been focusing on the health of women, adolescents, children, HIV and AIDS, and many other related areas. Let's put our hands together to receive Robin as he gives us her presentation. Madam Robin.
Thank you very much, Honourable Minister. In the interest of time, may I say all protocols observed. So thank you for the opportunity to speak here today. The presentations have been so very rich that all of the data that I thought I might share with you has been presented far more eloquently than I ever could. So I just wanted to pick up a few points that the Partnership for Maternal, Newborn and Child Health, PMNCH, has gathered as being particularly important lessons from the MDG era that we feel is important to guide forward. I think one of the core messages that comes through from all of the analysis of what's worked so far is that we need to ensure that all partners are included, that we have a truly multi-sectoral response, and that all those partners' efforts are aimed towards supporting one national strategy that is driven by the government. And I think in the statistics earlier we saw the real importance of strong government leadership in where we see excellent outcomes. As a partnership, PMNCH has fostered at the global level a unity across various different constituencies, including governments, donors, academics, health professionals, civil society and the private sector, as well as the multilateral system. One of the things we did recently was produce a piece of research known as the Success Factors. And the Success Factors for Women and Children's Health was conducted by PMNCH with WHO and the World Bank, and working very closely with Ministers of Health. Minister, as you said in your presentation, we do need to focus on what works. And what we found from analysing 20 years of data and multi-stakeholder policy reviews in 10 countries were some key findings. The first is really about the importance of addressing cross-sectoral determinants. Half the gains in mortality reduction since 1990, both child mortality and maternal mortality, have resulted from investments in the health sector. And the other half of the gains reflect multi-sector progress across health influencing sectors, education, women's political and economic participation, gender equality. Prof showed a slide towards the end of his presentation earlier that very neatly summarised those findings from the Success Factors study. What we also discovered through that study was the catalytic strategies. It's not just the interventions, it's also where countries have partnership and leadership, where they use robust evidence, holding themselves and each other to account, and have in place excellent planning for the short term and the long term at once. And finally, the third aspect of what Success Factors found was the guiding principles are essential, notably human rights-based approaches as well as national leadership, and that successful countries guide development partner investment into national priorities. And having spent a little bit of my time as a development partner, I know how truly important that is, that donors align behind country priorities. One of the 10 countries in Success Factors was Rwanda. I'm not going to walk through the statistics, that was done far more eloquently than I could ever do, but just to highlight a couple of key aspects about Rwanda. In addition to the stats we heard earlier, in 2013, Rwanda had 64% of its parliamentarians were women, and that was the highest percentage in the world. And the Success Factors found that where women were empowered and included in decision making, there were better outcomes for women and girls. You don't need me to tell you also that getting girls into education and girls getting through secondary education has a massive impact on health. Again, from Rwanda, we find that under 5 mortality is almost twice as high for children born to women with no education than those women who had at least secondary education. So those health influencing sectors are hugely important. Other lessons that we've learned around integration. In this region, we saw some striking data earlier about the impact of HIV on maternal mortality, and we know that where we integrate HIV and other disease strategies with broader population strategies for women and children, we get better results when we see the woman and the child as a whole person. And advocacy works. That's another of the great findings we have from the work that happened, scaling up the global community's efforts around maternal and child mortality, stressing the importance of MDG 4 and 5, which resulted in the global strategy that James mentioned earlier, and that is about now entering a process of renewal and updating. That had a massive impact on mobilizing and catalyzing energy, and that came from sustained advocacy at country level and in the global community. There's been a recent review of the global strategy, and the Secretary-General reported on the progress that's been made since 2010, and there were 5 key pillars that were identified as having been fundamental to why the global strategy has had some success. The first, as I've already stated, is strong political commitment and leadership. And so as we look forward to where we can get better results post-2015, this is something to carry forward. I don't need to tell you that, because obviously here in the East Africa community, heads of state have already recognised women's, children's and adolescent health as a key priority for the sub-region, and that's obviously something we need to see continue. But critically, we need to see that in national plans and priorities, multi-stakeholder partner alignment. Yesterday there was a multi-stakeholder consultation in advance of this meeting, and we heard some excellent stories from Prof. Mbonye, the Director of Health Services here in Uganda, about some of the success and some of the progress that's been made. He noted, for example, that parliamentarians in Uganda held up the budget approval process until there was a $30 million increase in the health allocation. And so we can see there that advocacy happens not just with civil society, but with parliamentarians taking an active role in ensuring that government delivers. We also know that the private sector plays a key role, for example here, as for providing 40% of the health services. So political leadership and strong commitment. The second area that was highlighted in the Secretary-General's review of progress on the global strategy is multi-stakeholder partners, and making sure that there's always inclusion of diverse partners in planning as well as delivery. Youth leaders in particular are critical throughout Africa given the nature of the population and the vast proportion that are young people. Again this week we saw an excellent gathering of young leaders here in Uganda and speaking out about their needs, particularly emphasising the need for sexual reproductive health and rights, comprehensive sexuality education, and for services to be provided that give them access to what they need and that will be owned by the communities. Thirdly, more financial resources, more predictable financing. As you may well know, under the global strategy, there were 400 commitments made, which totaled $60 billion, at least 22 billion of which was new and additional funding, coming both from domestic resources and from donors. As we look to the future, we look to potential new financing instruments such as the Global Financing Facility, and perhaps my Norwegian friend will speak to that, which we expect to be launched in July. Maybe he won't. But these new approaches to financing and the securing predictable finance flows and supporting and leveraging domestic resources should assist us in the post-2015 era, especially as countries graduate from donor support. And again, of course, being essential for donors to sit behind national plans. The accountability approach is the fourth key factor of why the global strategy has been found to work so well. Agreeing a set of indicators and an accountability framework has been central to making sure we stay on track, not just making commitments, but ensuring that we deliver on those commitments. And timely and quality data is key to enable planners to analyse the data, integrate it into policy revisions, and make sure that programs are meeting the highest priority needs. Linked to that is, of course, the importance of strengthening national civil registration and vital statistics, as well as health information systems. And finally, improving health in the future means focusing on the areas where we've not yet made much of a difference. James has spoken to many of these points. Stillbirth remains a massive priority, with 1 million stillbirths per year globally. Newborns, we heard again from Prof about the significant proportion of under 5 deaths which are related to the first 28 days of life. Adolescents, their needs were not captured in the previous global strategy and are a clear priority. And family planning. So in terms of moving forward and working with the EAC, well, PMNCH is extremely proud to have been invited to join you here, and we look forward to maintaining the partnership with many of you. I know that there are board members here and people who are close partners and collaborate closely with all of us in the efforts to move forward. We also know that through the Open Health Initiative to improve maternal, child and adolescent health, the EAC is supporting member states in their implementation of interventions that have been highlighted in the global strategy, and it's excellent to see that report in our delegate packs. So finally, I would end on the same note as James and say that we hope very much that as we move from 2015 into the new SDG era, we are able to plan a new global strategy for women, for children and for adolescents that reaches every woman, every child, every adolescent, everywhere, and is based upon your knowledge of what works best so that we can build from the ground up. Thank you.
Thank you, Robin, for that excellent presentation. We now move to our third presenter, Dr. Peter Waiswa, who is a medical doctor specializing in public health. He currently teaches at the Department of Health Policy Planning and Management at the School of Public Health, Makerere University here in Kampala. His PhD thesis was on understanding newborn care in Uganda, towards future interventions, a topic which is very relevant to what we are discussing this evening. Peter, you're welcome.
Thank you, Mr. Chairman. I'll straight go to the point. MDGs, what lessons, what do we learn? MDGs were quite ambitious and targets were set. And we know that when a target is set, you chase after a target. So you find that countries, donors, everybody for the last almost 20 years have been chasing after targets. So setting targets helps, and that's one of the key lessons. And when the targets are ambitious, then actually they help galvanize a couple of institutions. We see that civil society, NGOs, partnerships like the one we was talking about, the Global Fund, Gavi, and so many, were able to come to light to support the MDGs. And these MDGs helped some rapid decline that has been presented by many, especially Professor over here. But there were some challenges that, although some things actually have improved, like for child mortality, I call them the more easier conditions, diseases like malaria. If you have an antimalarial or you have an ITN, it will work. But for certain conditions that in the health system, especially for mother and newborns, we know that they have not worked. So I'll come back to that point. Now, what are some of the challenges that MDGs had? They had a narrow approach, a narrow focus. I mean, for us, we had a few conditions that we're focusing on. But we know that countries have a lot of problems, not just maternal, newborn, and child health, not just HIV, AIDS, and TB. So their focus on the health system was so limited. And we know that in Uganda and many countries, the MDGs, until recently, towards the end, they've not supported health system strengthening. Very little attention to equity. In fact, most of the MDGs focus on almost at national level. But at sub-national level, there was not much focus, even until the end, to the extent that even where we improved, the poor still have the worst coverage. They're also the ones who die. Also, one of the challenges for MDGs that I see is that the targets were defined, but how to achieve them was never defined. How does a country implement in order to achieve the targets? I remember working in the district and the minister coming to me, you need to increase the number of deliveries. I would ask them, how do I do it? Please teach me. So that's one thing that we didn't have. But MDGs also created some kind of dependence. Remember, apart from the SDGs, which have come now, the MDGs were quite vertical. And many countries were expecting donor support. And up to now, actually, many countries don't put much money in the health sector. We've seen what is happening in East Africa. All countries are not investing much, especially ours here in Uganda. We need to do more. So going to the post-MDG, what do we do? What can we do differently? Now, they have been called the Sustainable Development Goals. And it is said that there might be one goal for health with so many sub-goals that have not been yet set. Last year, we published a paper in The Lancet, which informed the Every Newborn Action Plan. And that paper, we showed that for Africa, if we continue the way we are doing, it will take a newborn in Africa 155 years to have the same chance of survival as those in the West, which they did so many decades ago. So, like Professor was presenting, even if we might achieve some of these targets, let's say in 2017, the digits are still high, like the minister said in his presentation. Even Rwanda, which we say actually has achieved MDGs or is doing well, its maternal mortality is more than 300 per 100,000. We need to do better. Now, right now, the world is talking about universal health coverage. This is an issue mostly from WHO, but I guess not many countries know how to do it. So the post-MDG, some targets have already been set. In the Every Newborn Action Plan, they've said that every country should have a neonatal mortality rate of 10 per 1,000 live births, the same for stillbirth. And there is a target being set for maternal mortality. I think sometime this year. The debate is about 70 per 100,000 live births. Now, so we see that the SDGs, or the targets that are coming post-MDG, are even much more ambitious. Do we have what it takes, to use the words of my professor? I think we must double the effort. I made an estimate that if all mothers came to deliver in hospitals and health facilities, and we achieved the cesarean section rate that WHO recommends, 15%, all our hospitals, Mr. Minister, will become emergency obstetric hospitals because all the beds will be used up. So as we set these targets, do we know what it will take, even given the population explosion? The other issue that we must do differently is our populations are sort of consumers. Right now, they are not major producers of health. They don't contribute. We have consumerism. I think we need the population to come on board to be able to contribute to improving health and not just governments. We need to invest in integrated care, which my colleagues talked about. The MDGs were quite vertical, malaria programs running as malaria, HIV program as HIV, and that is very inefficient. I think we cannot afford to go that way. We need to improve efficiency. We have limited resources. We must use the resources better. There is a study by HME and IDRC in Uganda, and they found that Uganda health system, Mr. Minister, is one of the most inefficient, even for the resources we have. It is more inefficient than Zambia, than Ghana, which they compare to. So this is an area that we need to do better. Now, country leadership, which my colleagues have emphasized. I think this is a time to take on health. It is our responsibility. It's not a responsibility of anybody. The donors can only be complementary. We need to strengthen service delivery where it happens. Many countries don't invest in district systems much. In Uganda, for instance, a health center too receives only about 1.5 million shillings a year. Of course, in addition to health workers. This is so little for them to be able to do anything. The decision space for a district director is quite limited. Partnerships. I like the issue of partnerships, and we have so many partners in the health sector. Partnership is an opportunity, but we must harness the partnership because a lot of the partners, they may get approval from a minister, but they go and do their thing. We must align them to country programs, even financing. We recently made a study on where does the money for immunization come from and where is the money. And we found that most of the money is actually outside. The Ministry of Health doesn't have control over money. When they want to go and supervise, they have to go to partners to facilitate that. I think partners must be aligned. Finally, two more issues. One, measurement. My colleagues have emphasized it. Measurements is going to be important. We must have national targets, but also local targets. Districts must have targets, and we must have innovative financing mechanisms so that we are able to improve the amount of resources available in the health sector. With this, I recommend universal health insurance, where everybody contributes, or at least everybody is cared for and has power to choose. I think if we do this differently, then we have a good future going into the SDGs. Thank you.
Thank you very much, Peter, for that informative presentation. I'm sure the panelists see that I'm a very lenient chair, but when you are presenting, you keep looking at me. When you see me looking at you, then it means I am about to remind you of the time. But thank you very much for the presentation. I think we are doing very well. Let me introduce the next presenter, who is Mr. Austin Davis. He has a long experience working in health issues, the NGOs, the UN, governments, and has worked long in the East African region. Currently, he is the Senior Advisor for Global Health at the Norwegian State Development Agency, NORAD. Again, I cannot go deep into his CV, but a very experienced friend of ours. Let me invite you to give us your presentation.
Thank you so much for inviting me. All of your excellencies, I won't go through thanking everyone because of the time. But just to let me say, I'm so happy to be here. I consider East Africa to be like a home, a second home, Kampala, as you suggested. In fact, my third daughter was born in East Africa. So if you can imagine a small white 5-year-old girl wandering around snow-ridden Norway, and everyone she walks up to, she goes, "I'm African." So she's a great advocate and a mover and a shaker for you. So I've got only 5 points, so I'll be quite short. So the first thing, one of the reasons why Norway partners with the East African Secretariat on the Open Health Initiative is we understand the East African Community Secretariat is principally interested in economic integration, infrastructure, trade, monetary integration. But what we would like to share from the Norwegian experience is that the reduction of maternal and child mortality is not just charity. It's not just the right thing to do, and it is. But it is also much more important than we thought, even when we formulated the MDGs. It is central to the formation of modern progressive societies and economies and polities. You cannot have a modern, progressive, dynamic society with the kinds of fertility rates and death rates that we see in these countries. So it is in the interests not just of the first ladies, but of the first gentlemen. Secondly, it is of critical interest to not only climate change, but environmental preservation, which means the health and well-being and enjoyment of life for all of the East Africans that will come afterwards. And someone mentioned the explosive population change. So Africa has the blessing of being the place where the most children are going to be born on Earth in the next 30 or 40 years. And that is fantastic and does raise the opportunity of a demographic dividend, but also can be a threat to a demographic disaster. So if all of the beds would be needed in all of the hospitals just to deliver the babies that are being born today, and you're going to have 30 to 40% more deliveries in the next 20 years, you have to think about the capacities you have, not just to go forward, but to stay standing. So we really need to think about strategies to reduce maternal and child mortality in this area. It is essential for progress, and it is a big challenge given the population growth. The second thing I'd just like to say is there is a lot of optimism in the world that many countries are growing economically and that many countries in Africa have shown very strong economic growth. And the projections are that both with economic growth and an improved tax base, many African countries will have far larger budgets into the future. So that even if they only commit the same percentage to health, that amount will go up enormously. And if they increase the percentage, it would even go up even further. And concomitantly, people believe that therefore there will be lower investment flows from development partners. So what you're seeing is a kind of weaning, a reduction of development assistance and an increasing domestic financing. And I think that's very good news in one way, because it squarely places the responsibility on your countries, your people, your leadership, to resolve their own priorities and then to act and to really make it happen. rather than to have people like me coming and telling you what to do because we give a bit of money. So we're looking at a transition phase whereby we're seeing a much, much greater demand for sovereign and domestic leadership. The third aspect I would say is, if you look at the global burden of disease study, there is only one region in the world left where communicable diseases remain the principal cause of death. So for the rest of the world, they're looking at non-communicable diseases. And the SDGs are an entirely different animal to the MDGs. They represent a compact for every country in the world, and so they're not as focused on development priorities around certain countries that are left behind. And so you are increasingly alone in this agenda as Africa. And whilst there are many, many friends who really want to finish the unfinished business, it is no longer the central, and it will increasingly be less so, the central determinant theme of health discussion between the nations of the world. And so there is an enormous imperative. I mean, you will face that double burden of NCDs and communicable diseases, but a lot of the communicable disease thinking you'll be partially alone on. So what lessons? I mean, Robin has already talked about a lot of the lessons learned. We have done a lot of science. We have got a whole load of new tools and technologies that can be applied quite cheaply. But we're finding that in many places, when they're applied, we have tremendous results, and in other places they don't. And that there are real differences by country to country, and some countries achieve a lot more health for the money than others. So the policy environment and getting it right is really important. And Norway would like to stress, and I think has already been stressed, that the notion of accountability and metrics. For doctors in the room, the analogy, many people, when they're looking at a budget and they have to cut, they will cut the surveillance and M&E. And that's partly because they don't find it useful. Can you imagine a human body without a nervous system? How can you tell whether the body is being damaged or improved? How can you, the whole human body ceases to function without its nervous system, and your information systems are the nervous systems of your health systems. Much of the accountability in the past MDG period, which is considered to be successful, has been a form of information and accountability up and out of your countries. And there has been insufficient attention to building dynamic and important information systems that deliver information inside so that you can manage and get the best efficiency out of your healthcare systems. So just one example, I've been in 8 African countries in the last 8 months, and I saw him. And I don't think in one of them, did the BMONC level work. So you can talk about shock garments or magnesium sulfate, but if your community to primary healthcare level to secondary to tertiary does not work, then your health system's not working effectively. So you have to move towards the quality management of the health system, getting efficiencies out of the health system. Equity is extremely important. Make sure everyone benefits before you go to the next level of technology. And only 50% of our benefits have been raised within health. And so we need to work within our colleagues, with our colleagues in education and water and sanitation, to make the case for human capital and not just health versus education. We don't want the education budget to be cut. We want that to be increased as well. Women have to be educated to realize this agenda. So thank you very much.
Thank you very much, Mr. Davis, for your clear and informative presentation. Thank you very much. Let's give him another round of applause for his presentation. Let me now turn on my right, and I invite Madame Rory Sirowet, who also has a wealth of experience in the field of health. She has worked in many countries in Africa, in Asia, for various UN agencies, including WHO, and currently she is the Deputy Director, Advocacy and Public Policy at the Gavi Vaccine Alliance. Madame Rory, you are welcome.
Thank you very much. I'm very happy to be here. As many of you know, the Gavi Vaccine Alliance are great partners of the EAC, and a lot of work being done in the country, so couldn't be happier to be here. I think in terms of listening to all the presentations today, one thing that really strikes me is sort of how do you position where we are? Is it good news? Is it bad news? And so it's the optimistic look of really, if you think about where we are today compared to 1990, there has been this really sharp reduction in illness and death in maternal and child health. So while we haven't achieved the targets, it is phenomenal that today there really are 17,000 kids every day dying, less than they were in 1990. And so I think as a community, we really have come together and have learned a lot towards that lesson in terms of what works and what doesn't. But I think this also serves then as an inspiration of what we can do going forward, because there's clearly a lot more that we can do. We have missed the targets in terms of maternal mortality and also child health, but really half of the children being born, it still means that 17,000 every day are still dying. And so what can we learn in terms of lessons going forward in the post-2015? I do think we need to do things differently, and so what I've, just in terms of the Gavi experience and working with partners in the countries, what are some of those main lessons that we've learned? I would say the first would be the role of innovation and technology and incorporating that in the programs. And I think the example of vaccines and working with the countries is probably one of the strongest cases in terms of new vaccines. If you think about when the MDGs were signed, pneumococcal, rotavirus, these vaccines weren't really used. And if you take the recent example of HPV, it's incredible that it was actually finished its clinical trials in 2005, was recommended by WHO in 2007, and then piloted in some of the low-income countries in 2008. And in terms of Gavi, that was really only in 2013 where we started rolling out the first pilot program, I believe, in Kenya. So you can see that we still have a lot to do. We didn't even know a lot of the things that we know now when we were starting off with the MDGs. So going forward, I think we can take the innovation and technology even further. In the case of vaccines, there's a lot more we can do with cold chain equipment in terms of the solar fridges, or making the footprint less for the vaccines by adapting vaccines themselves to heat-sensitive environments and other technologies. And it's not just in vaccines. I think if you look at the platforms and some of the things that the countries themselves that you're all doing, I saw in the SG's report a great example of, for example, with the ICT, there's in Kenya, and someone from Kenya can probably know more about this than I do, but with Safaricom, they're actually using the mobile technology to have their alert system to flash people when there's a delivery date, when the next clinic visit is, what the immunization schedules are. So how do we take examples like that and, as people say, scale them up or make them more applicable globally? But I do think discussions like this help that, so it sparks innovation and ideas across a wide range of areas. And also in terms of the role of the EAC, in terms of what you've all done, it's what are some of the lessons learned in terms of we have adapted those technologies in terms of the new vaccines into the national health programs. So that's a success in itself. And so we're doing well in that agenda. The second overall lesson learned, I would say, is in terms of the types of partnerships we have. And a lot of people talk about the public-private partnership. But what does that really mean, and what does that look like? And so I think, again, looking back at when we all signed on to the MDGs, in terms of the global partnership, the MDG 8, the organizations like PMNCH and Global Fund and Gavi, none of those partnerships had even been formed yet. So again, in the last few years, looking at those models and working with countries, we've learned a lot, and we need to use that as the basis going forward. And I agree with Robin that the primary lesson there is that it's country driven. It needs to be at the national country plans and aligning the partners, as others have said, to the national agendas. And so in the case of Gavi, that's been really well, it's taken forward in terms of it is country driven. What is the burden of disease in the countries, and what is the national plan, and then applying for support from Gavi, but while co-financing and helping to pay for that, and gradually making so that it's affordable within the national health programs themselves. So I think in terms of that, working with countries, that's very important. And then there's other things that we can do differently in terms of the market shaping, right? So if you really think about that countries, it was expensive for these vaccines, and how do you actually work with pooling demand in the countries that need it most, and working with pharmaceuticals to drive the prices down and increase the supply. So I think this type of model could perhaps be used for other commodities going forward in terms of the maternal and newborn child health agenda. And just one last thing on the partnerships and what we've learned, and it goes down to the accountability as well, I would say, is that it's results, that you can see clear results from the work that's done together, but it can't be done by any one agency, country alone. And so, again, in the case of Gavi, since its existence with the countries, we've achieved great results in terms of saving 7 million lives and vaccinating nearly 500 million children. So again, like you were saying about the nervous system, I think that's really interesting because when you see things that are successful, you learn from them and you can move forward, but you can't do that without good data. And finally, I'd say the last sort of overall lesson learned and where I think we could do better is a lot of people here have mentioned that vaccines can be the mechanism or the platform to have other types of health services. And a lot of you have already done that in different examples. But I'd say I think we need to take it one step further and have, as Robin was saying, much more of a multi-sectoral approach. So it's not just about integrated health services, which is great in terms of the ORS or the zinc or antibiotics or deworming. When you have the platform of immunization, there's a lot of variations you can take. But I'd say going one step further and saying, how do we work with the other sectors in terms of water and sanitation, but also with education? So one of the things that Gavi is working on now going forward, and I know that I was speaking with your EPI manager today in terms of the HPV and the platform that can provide to a group that really has not been targeted in the MDGs and one that's really been left behind, and that's the adolescents, and particularly the adolescent girls. So how can we work with the HPV program to reach out-of-school girls? How can we work with schools themselves to make sure that there's more integrated approach across maybe bringing the girls back into education or teaching menstrual hygiene or having better sanitation in some cases? With the EAC, I think the rates in terms of out-of-school girls is relatively lower than other. I think it ranges from 9 to 16%, but it still means that some girls are being missed, and how do we reach those girls? So again, a type of platform that can be provided to have a wider range of services, because it's really about the multiplier effect. It's hard work, it's not easy, it's not natural for us to think, okay, I've got 8 million things to do, and how do I actually now include education in that as well? But if we can all see what the results could be going forward, it makes the work worth it now to try and do that.